Ladies and gentlemen, we are going to move into our opening keynote presentation with Cathy Reid. Cathy, Digital Advisor with Icon Group, Managing Partner with the Epic Pharmacy Group. Let me tell you a little bit about Cathy. She joins us this morning to talk on the topic of digital disruption in healthcare, amongst other things. She hails from Victoria. She has called Brisbane home, though, for nearly 20 years. She is the co-founder of Australia's Epic Group, including Epic Pharmacy and the Epic Good Foundation, and a digital advisor to the Icon Group board. Co-founder of the Icon Group, Australia's largest provider of integrated cancer care services and Singapore's largest medical oncology provider, with reach now extending into China, Southeast Asia and New Zealand. And as you've seen, we have got our New Zealand contingent. How good is it to be a New Zealander at an Australian conference and to stand and get an ovation from an Australian audience? It doesn't happen very often. Welcome to you. Cathy is chair of ASX-listed Createch, only the second company ever to list with a female chair and a female CEO. She's the winner of the National Telstra Businesswoman's Award in 2011, Monash Uni Distinguished Alumni Award for Professional Achievement in 2012. Cathy was named one of the top 100 women of influence by the Financial Review in 2013 and was inducted into the Australian Businesswomen's Hall of Fame back in 2015. She is also a board member of the Brisbane Lions. Very excited that the Brisbane Lions women's team are going to be playing in the inaugural AFL Grand Final, which will be held, I believe, somewhere this weekend, to be advised. If that's not enough, she is also part of Virgin Galactic's Future Astronaut program. Cathy is looking forward to having the opportunity to go into space in the not too distant future and is currently enjoying all of the training and preparations for that in the meantime. Ladies and gentlemen, boldly going where no man or woman in this conference has gone before. Please put your hands together as we take one giant leap with the epic and iconic Cathy Reid. Welcome, Cathy.
Thanks very much, Andrew, for that lovely introduction, and thanks all for joining us here in not so sunny Brisbane today for the conference and what's sure to be an exciting couple of days ahead. So I'm sure we've all seen these kind of headlines, read articles on this topic, sat in presentations around how big data is going to transform healthcare. It's going to completely change our industry. It's going to change the way we operate our facilities, the way we deliver care to our patients, and completely revolutionise healthcare as we know it. And I do believe that that will happen, that big data will deliver significant transformation into the healthcare industry. But at the minute, so much of our data looks like this. It's still stored on pieces of paper, in files, in cabinets, whether that be our patient data or whether that be many of the other pieces of information that we need to run our facilities and do our job and deliver our care to our patients. We've got a small data problem still as an industry before we can actually start to harness the power of big data, and we need to work our way through resolving that, hence the somewhat inflammatory nature of the title of this presentation that Michael bestowed upon me. So today I want to talk a bit more on that challenge. If you've come thinking that it's going to be a Matrix style presentation where I'm whipping things out of the sky and touching and conjuring up all of this digitised magic, unfortunately that's not what we're going to get today, because entertaining and informative as those presentations are, what does tend to happen after you sit through a presentation like that, and I've sat through many of them all around the world at healthcare conferences and events, they're fantastic, but you walk away and this is often the response. Because you go, that is fantastic, but it's so far away from where we are today and where my organisation is and where I can see my organisation going any point in the near future. So I'm just going to stick my head in the sand and I'm going to really hope that somebody else does the heavy lifting to be able to deliver on that promise. You know, maybe the government's My Health Record will finally unlock the door of connecting all of that patient data that we want and deliver that. Maybe other people will do other things. In the meantime, I'm just going to pop my head down in the sand and because it's all just too hard and it's all just too big a challenge. But the unfortunate thing is that what tends to happen if we stick our head in the sand is no matter how long we wait before we pull it back out again, not too much has actually changed. So what I do want to talk to you about today is how we can start to solve that big data challenge, that small data challenge rather, to take us along that journey to digitised information where we've got our data in formats that's accessible, that's allowing us to run our facilities better, and most importantly, to improve the care that we're delivering to our patients by having information at hand wherever we need it, the right type of information that allows our people to play their roles more effectively and to deliver the best possible care in the most cost-effective manner to our patients. One of the things that I like to think of data in terms of when we're looking at it is essentially data is like the dots on a page. It's probably, well, actually with the resurgence of adult colouring books, maybe some of you have done join the dot drawings since childhood now. But if you think of those dot to dot drawings, the number of dots that you can actually put on the page actually has significant impact on how clear the picture is. So our elephant there on the left, you can tell it's an elephant. You can see the outline of the elephant, but you haven't got a whole lot of detail about him. You don't know all that much about him. The elephant on the right, however, there's a lot more dots on that elephant. It's painted a much clearer picture of that elephant and what he's all about. And that's what data is essentially. Data is just dots that allow us to add more of those dots to deliver that clearer picture, whether it be a picture about our patients or whether it be a picture about a business problem that we're looking at solving. So the more data that we can actually turn from paper-based records into dots, that we can paint that picture, develop a clearer picture there, and actually be able to better understand what the challenge is that we're looking at because we're more informed. To keep with our elephant analogy though, it's a big problem and it's a big challenge and it's a big process. So how do we actually start there? We've got to actually determine, it's a bit like eating an elephant. We start with one bite at a time. That's all you can do. No one can swallow an elephant whole. You've got to decide how you're going to carve it up and how you're going to get stuck into it and digest it and break the problem down. And our move from our small data world at the moment into the big data world follows that pathway. We've got to pick which part of the elephant that we're going to start eating, pick up our knife and fork and start to get stuck in there. But like every journey, if you don't know what your destination is, you're really, really impacting your chance on actually getting there. So when Michael and his team were deciding how they were going to get from Brisbane to Canberra, from Canberra to Brisbane, they actually had to know that was where they were heading, because if they just picked randomly, they could have ended up in Perth, and then it would have been a very different story for the conference today. So determining what your destination is a really important part of the process. And for the leadership of your business, understanding what your ultimate digital destination is the first part of the process. And it may also be a multi-stage journey that you decide, look, much as we would like to be a fully digital hospital, we just know that we're not going to be able to get there in the next sort of maybe 5-year window. But what we want to do is we want to actually, at the end of 2 years, we want to be here. At the end of 4 years, we want to be here. At the end of 6 years, we want to be here. And we know that we're keeping on making progress along that journey. And the route that you take to get there will be determined just in the same way as Michael and his team were looking at and how they would get from Canberra to Brisbane. There's always multiple routes that you could take. You know, they could have flown a plane, they could have ridden a bike. I don't think too many of them did. They could have walked, I'm sure that's even less likely. They could have driven. I'm sure the route that most of them took was they flew here, but in looking at what the options were available, the path that they took and the journey that they took was defined by the resources that they had available to them. And those resources weren't just money, they were time, and they were the availability of the people and what committing the people to that journey meant for the impact that it would also have on the other things that those people may have been working on within the organisation. So the first step along the process is planning when you want to get to, and then looking at the way you're going to construct the journey to take you there based on the resources that you have available to you. Now, you may be in the fortunate position that you can take the Big Bang approach. You might have a budget like the Royal Children's Hospital, who've just done that. Over the weekend, I was reading an article about that. It seems to have gone quite successfully, but they've spent $46 million to get there. And looking around the room, I'd suspect there's not too many of us who've actually got $46 million to commit to a full-scale digitisation project. So I'm going to work on the assumption that that's not the path that we're likely to take, and that's not the way we're going to actually take that journey to get to our destination. And talk more about the approach that we've taken in some of the activities that we've done and some of the things that I've seen around the world that focuses on a more medical way of looking at things by looking at where does it hurt? What are the pain points within the organisation? What are the things that we can best, that if we fix these problems, we can actually deliver real, impactful solutions that help our people have the chance to do what they want to do best, that help our facilities to run smoothest, and of course, deliver on that ultimate goal of delivering fabulous patient care. One of the real benefits in going to your people and asking, where does it hurt? What are the things in your job that you do that absolutely drive you mental, that seem like the biggest waste of time, where you're duplicating workload, where you just feel like what you're doing is actually creating no value whatsoever, is a very powerful exercise. It can be quite confronting because some of the answers, and particularly when we're in management positions and it's a while since we've actually worked in those coalface roles, it can be quite embarrassing to actually go, really? Really, we're making you do that? We're making you fill in that same form three different times? And asking that question, though, does actually give a huge amount of information, because people will always tell you the things that they hate about their jobs. They're very, very happy, firstly, that someone's wanting to listen, but secondly, if you can then work with them proactively on delivering a resolution to that problem, not only have you increased their engagement, you've empowered them by asking them, making them part of the solution. You've also built their trust because you've listened to them, you've heard them, you've enacted on that change, and you've actually created an environment now where the next time you go to them with the next step along the journey and say, look, now we want you to do this, you're starting from a position of trust where your workforce is going, actually, well, that last thing they fixed for us, that was really good. That's really made my life easier. So you know what? Chances are the next one's actually going to be the same. So asking that question of your team members, where does it hurt? What are the things that are causing you pain? Has been a really effective way for us in determining where our start points are and the route that we take to get along our journey. I want to illustrate that it doesn't all have to be high-tech, high-cost as well. Capturing data and creating more of those dot points to give a clearer illustration to the picture doesn't actually have to be anything really significant. This is actually not an illustration from a healthcare facility. This relates to a manufacturing business that we used to have, where we did medication compliance packaging. And the premise of that business essentially was lots and lots of different machines, all filled with different medicines. Orders from pharmacies all around the country would come through, and the machines would run and produce all of this packaged medication to distribute back to pharmacies for delivery onto patients. One of our key metrics as a leadership team there was, how do we actually keep those machines running for as many minutes as possible each hour of the day? Because the more productive the machines could be, the greater the output was and the more we could do in less time. And the machines themselves gave us great data on how many minutes out of every hour they were running for. And so we had all of our KPIs set around that. But we needed to understand how we could actually influence and change the number of minutes that the machines were idle for. We need to understand why they were idle and then what we could do to fix that. So what we did was we actually just hired a whole pile of little trackers, and we got all of the workers to clip these trackers onto their clothes for a week and see where, and produce a map like this that actually showed where they were in the facility and where they were going, because we knew that the downtime from the machines related to the machines, something needing to be put back into the machines, whether it was medicines, whether it was paper, whether it was any of the other consumables, assuming that they hadn't actually had a breakdown, which we knew about as a separate event. So by mapping the facility and seeing where people were walking and spending their time, we realised that we'd actually made a flawed decision in the planning of the layout. We decided that the best place to put the bulk of the consumable products was together in a singular storage area, where it meant that we had great visibility of our inventory, we knew exactly how much stock we had at any given time, and we didn't have it scattered in random places all around the facility and not know how much of, and have to go to multiple places to count it and to refill it. Turned out it was the wrong decision, because what the data showed us was that people were actually spending their time going to the same locations multiple times each day that were quite distant from where the machines were to refill, to access those products. So we broke the storage down into small, close-by locations near each of the machines. You know, it's not rocket science, but the data showed us that that was what we needed to do. We made that change. We put the trackers back on everybody for another week, and we could immediately see that map looked really different. But then also what happened was our machine minutes per hour went up immediately, because people weren't having to take the time to walk anymore. And the reason that I wanted to present that illustration today is that I'm yet to meet a coalface healthcare worker who actually has trouble accessing their 10,000 step goal each day. Our people walk for miles. You never want to be the person in the, you know, we all run those sort of 10,000 step challenges. You're never ever going to actually be able to beat the coalface people on the ground delivering the services to the patients if you're sitting in a desk in your office. Every time we start those, we go, oh great, we're going to lose these again. We're going to be pounding the pavement for hours after work, trying to get our step counts up and make up for the fact we're sitting at a desk all day. But if we can understand where in our facilities our people are moving to and be looking at whether that's productive use of their time or whether that's non-productive use of their time, that's a really interesting illustration, and one that's easy, cheap and quick to achieve. The next one I want to talk to is a bit different. Took a little bit more time, cost a little bit more money, but also delivered a lot more benefits than we thought were achievable in that initial pain point discussion. So this was a project that came around initiated by some of our pharmacy teams, whose hospitals had been selected to participate in Medicare's paperless script pilot. So what the problem was there was that the thing that they'd identified, their paper storage was going to, ironically for a paperless pilot, it was actually going to vastly increase the amount of paper that we had to store, because the prescriptions were being removed, but Medicare still needed a source of truth document from pharmacy to be able to review in an audit to check that the charge that had been levied to Medicare for the PBS item was actually legitimate. So we were facing a scenario where we were going to have to, in our ward rounds, photocopy all of these medication charts, bring them back to the pharmacy, and then use them to dispense from, and then put them in a box and keep them accessible to be able to refer back to any time there was a query about that prescription or in the event of a Medicare audit. So they said, you know, is there any way that you can actually design a way that we can capture the charts electronically and then store them electronically in a way that's going to be easy for us to reference them at the time of of an audit or a query around those. So that was the pain point that was identified. But what we did was we got our digital team and we said, you know, I mean, yes, it's ignore the fact that it's a healthcare record, but you could actually take a picture on your iPhone and email it back to the dispensary, job done. But so long as you used an encrypted source and didn't just have pictures of charts sitting on people's phones. But what we did then was we sent the digital guys in to sit in the dispensaries with the pharmacy teams and look at their work patterns and understand what they were doing and say, well, if we're going to build this tool, can we take it a bit further? Are there other pain points here that we can solve? Are there other benefits that we can deliver? And what they discovered was that when those ward pharmacists were going out to do their rounds and they'd be out there, they'd be gathering up all of the different pieces of paper and the different information sources, and then they'd come back to the pharmacy with this tsunami of work hitting. You know, everyone in the dispensary would sort of be sitting there, getting things ready, getting stock unpacked, you know, doing all of the tasks, waiting with bated breath for when the first of the pharmacists would arrive back with orders aplenty. And then this frenzy of work would happen because each of the wards would have a deadline that the orders had to be fulfilled by and send them back. And it was all very, very stressful, and then everyone would breathe a big sigh of relief. We've got through that, sit down, then it'll all happen again in the afternoon. So there's actually multiple pain points here that we can actually solve. And one of the things that we can do is not just build this tool that takes a picture of the chart. If we actually turn it into a workflow tool as well, what we can do is have the pharmacist do the ward round, take the picture of the chart. I don't know if you can see the little dot up there, and then that it's all blanked out because this is a real chart and a real patient. But what it'll actually have up there is multiple dots on the chart and then notes associated down at the bottom that say what the instructions are, whether it's a new order but you don't need supply because they used ward stock for this, or this one we do need supply, or whatever instruction the pharmacist wants to give. Before they leave that patient's bedside, after they've taken that image and jotted those notes down, that instantaneously gets sent back to the dispensary where it pops up on the screen. It's aligned next to the dispensary software, so the person back in the dispensary is actually immediately able to start working on that before the pharmacist's even moved on to the next bedside. They've got their source of truth document on one side of the screen, and they've got their dispensary program on the other side of the screen. So what that means is it's a lot less stressful for the people in the dispensary because they're able to match their workflow through. But what it also means too is the pharmacist who's actually doing the ward rounds doesn't have that ticking clock in their head going, I've got to get back, I've got to get back, I've got to get back because we can't start on the orders until I get back. They can actually spend more time with the patients. They can actually talk to the patients more, understand more of what's going on, knowing that they're only ever one bed behind in the dispensary. And that's really transformed the way that whole workflow operates and that whole dispensary process operates, which has made a huge difference to those teams. Again, it's also given our managers and the dispensary leaders the ability to actually have a really clear picture. The way they used to get the picture in their head of how the dispensary was going and where those orders were in the process and the flow was to, pop their head out of their office and almost take a frenzy check. How crazy is it? How much adrenaline is running? How are we going? Is there anybody who needs anything else? Are we late with this order? Where are we running at with this? Now they can actually pull up on their screen. They can see exactly how many orders have come in. They can see who's working on those orders and what process they're in. They can see how those there is a ticking clock still that actually shows colour-coded whether the orders are on track and going to meet their deadline, whether the deadline's approaching and there's still a few banked up, so they can allocate their resources accordingly. It's given them a really clear picture of what's going on, both in the immediate way they conduct their day-to-day activities, but it's also given them a really good illustration. They now are able to access and understand very easily which wards generate the most orders, which wards generate the most urgent orders, how many orders we get on a week, does that pattern change on a daily basis? All of that information is there now captured. It used to be in pieces of paper, and it was, yes, you could go back and you could build spreadsheets and you could collate all of that, but it was hard. So nobody ever bothered to do it unless we had to do it for a report or something else because it just wasn't easy. by that one simple conversation where a team member said, hey, this is a pain point that we've got. This new pilot has come in. We've got an opportunity to do something different. We were able to extend that thinking. And again, it certainly cost more than just hiring some trackers and clipping them onto people's belts and seeing where they moved around the facility. But it certainly didn't cost enough to not have delivered vast, vast benefits in terms of the information that it delivered and the benefits that it's been able to achieve in our work and planning. This one is not one of ours. This is actually a study that was done in the University of Utah Healthcare in the US. But I want to talk to you about it today because I think it's really interesting to note that in the same way in the last example, the initial pain point ended up being able to be so much more. It's also possible that the premise around what you're actually trying, or the proof point of what you're trying to think that you're doing with the data you're capturing, may end up giving you a completely different answer from what you were expecting. So the University of Utah Healthcare were running a project where they wanted to understand with their orthopaedic surgeons whether they were getting the same patient. They were using two types of prosthetic hip replacement devices. One was cheaper, one cost more. They wanted to understand what the patient outcomes were in terms of patient recovery time, side effects after surgery, and in general, whether the choice of prosthetic used made any difference to the outcome that the patient achieved. I don't suspect too many of us would be surprised by the outcome they were hoping for. They were clearly hoping that they were going to be able to prove that the more cost-effective joint replacement delivered just as good an outcome. But what they found, and they did find that, they found that there was no difference whatsoever in terms of outcomes depending whichever joint was used. Completely the same. Nothing statistically significant. What they weren't expecting, though, was they found something else that actually gave them a very, very different answer to the one that they'd originally been anticipating. And what they found was the time of the day of the surgery had an enormous impact on those patient outcomes, regardless of which joint was used. Because what was happening was the patients who were having their surgery late in the day, by the time they came out of recovery, the occupational therapist's shift had finished and they'd gone home. So those patients weren't able to be mobilised on the day of surgery. And to a T, they all had worse outcomes than the patients who'd been operated on earlier in the day and were able to be mobilised on the day of their surgery. That wasn't the answer they were expecting to have revealed at all, but the data was able to identify a completely different problem than the one that they'd originally scoped out. So what they did was they increased the shift of the OTs. They put on more OTs and delivered on a premise that every patient had to be mobilised on the day of their surgery. And they completely normalised the outcomes. They removed that differentiation completely. And then I'm sure what they went back to the surgeons was and said, hey, it makes no difference in the joint and we've funded extra OTs to be able to improve your patient outcomes. So if you could actually shunt yourselves over to those cheaper prosthetics to help us pay for that, that would be much appreciated. That wasn't part of their presentation, but I'm sure it's not hard to imagine that conversation probably happened. So we never quite know when we start to capture this data and to paint our picture, and we never quite know what's actually going to be revealed. So it's important to stay open-minded during the process. Another pain point of ours that came up in our conversations was our surveys. Every year we do an internal survey and we do external surveys with the organisations that we deliver services to, and surveys from our patients. You know, it's actually a requirement in many contracts and in many accreditations to be able to gather this sort of data. That survey's we've been trying to digitise it to some degree for years, but both our internal teams and the external teams, there's still a lot of people who just don't have access to computers and particularly when they're in that frontline healthcare service delivery, they don't want to be sitting there filling out a survey on a day-to-day basis. So the survey planning exercise every year is a really big task. You've got to go through and make sure the questions are still relevant, define those, figure out what medium you're going to conduct the survey in, operate for the survey period, get all the results back, collate the results, build some reports around the results, get your managers together, talk about what the results show, build any action plans around what the results have revealed and implement on those, and then wait a whole year to do the survey again before you figure out whether any of it's actually had any impact. Not a particularly great proactive way of understanding what's going on in organisations. So, many of you may have seen these devices, particularly if you've been in airport toilets and going through airport security. Often, most of the Asian airports now tend to have these. They're called the Happy or Not kiosk. And one of our customer organisations actually in the aged care space, we were talking with them, we'd gone for the meeting to present the survey results to them, and they said, look, we've actually just seen this and we're thinking that we're going to start moving to something like this. And we thought, how fantastic is this? Yes, it's four buttons. There's not 5, as the typical survey has, but it's a really, really simple premise. You ask the question, internally, we say, how are you feeling today? For the external facing ones, we say, how are you feeling about our service today? And people hit the green button, the smiley, if all's good, they hit the green button with the smiley face. If they're not happy, they hit the red button with the angry face, and otherwise they'll hit somewhere in between there. But it allows for that capture at a moment in time that's really, really instantaneous and accessible. It gives us that information on a daily basis. We don't have to wait a year for it. We can understand what's actually going on in our organisation, how our people are feeling about their roles, how our customers are feeling about the service they're providing, how our patients are feeling about the service that we're delivering. You can see the type of reports. It's a bit ironic, they're paper-based reports here, but this was just a stock photo of Happy or Not that I took. We do get them in digitised form, I'm happy to report. But they actually show day by day, hour by hour, what people are feeling at that given time. And if you can see that every Tuesday afternoon the angry faces go up and the bars of red go up, it's pretty obvious that you've got a problem on a Tuesday afternoon, and that problem probably translates to rostering, that you haven't actually got enough people on to meet the need. If it's a consistent one, or if it's a once-off, it might be that you've had some sort of system breakdown or something's gone pear-shaped on that given day. But it means that our leaders of sites have got real visible information literally every day. We tend to look at these on a weekly basis. Now, when we first got them, we were so excited we looked every morning. Now we tend to look every week and see the patterns emerge. You do have to take some of the information with a grain of salt though. One Monday morning, I got the reports for one of our pharmacies up at Toowoomba. It was an internal facing question around how are you feeling, and normally, the reports, particularly the internal facing ones, they tend to illustrate things that you're already fairly aware of. If you've got a site that's having big HR dramas and your HR team is spending a lot of time there, you don't open those reports expecting to see a sea of green. You expect to see a bit of red. But equally, it's a shock if you open a report, as I did that morning for the Toowoomba report, and a site that wasn't on our radar as having any problems at all was just a sea of red. So I rang the pharmacy manager and I said, look, have you opened your Happy or Not report yet? He goes, no, I'm getting to it shortly. And I've gone, what is going on up there? It's a sea of red. Your people are really, really upset about something. There's something bad going on. And he goes, because I got no idea. So I thought everything was fine. I'm calling a staff meeting straight away. I don't know what is going on. He rang me back an hour later and he goes, yeah, I've got to the bottom of it. He goes, turns out one of the juniors' boyfriends cheated on her last weekend and she was really, really, really angry with him. So every time she walked past the Happy or Not kiosk and saw the sign, how are you feeling? Boom, red face. Boom, I'm still red face. I'm still red face. Nothing whatsoever to do with the workplace. But the positive out of it was, he said the team was so impressed that like by 9:15 on Monday morning, I'd had a call to say, what's going on with your people? Why are they so upset? So he goes, it was kind of a bit of a win because it showed them that people did care, people were noticing their feedback, and that it was real and it was actionable. So you do sometimes have to take it with a grain of salt, but it's something that we've found to be way more beneficial in terms of the information gathered and the way that we're able to utilise and deploy that information than the annual surveys. We don't keep them in the same place all the time unless it's a patient-facing one. We tend to keep them there longer because different patients are coming through and you want to get that finger on the pulse there. If it's the same people doing it all the time, though, they do get device fatigue and they do stop hitting the buttons. So we found that we need to rotate them in and out. We also will put them somewhere, if it's a new service implementation, we'll generally try and get a kiosk in there pretty quickly to get a sense of how people are actually feeling about the service. If we've had a major change, change the layout of a site or a major workflow change or a management change, we'll tend to put one into a site as an internal facing question to get a finger on the pulse there. But again, really cost effective, really cheap way of being able to access data and to paint that greater picture than we had previously. So if you decide that you actually want to, as you're going down this pathway and you're thinking about, well, it's all very well, how am I actually going to find those different pain points? How am I going to get people to buy into this and start working out our pathway? My really, really strong piece of advice is don't appoint an innovation manager or an innovation team, because by all means, have somebody running and leading projects. But in our experience, we've always found if you give someone the job of innovation manager, then all you're doing to everybody else is saying, innovation's not my job. That guy, he's the innovation manager. It's up to him. He's the one who has to come up with all of the ideas. Nothing to do with me. I'm just here doing my thing, waiting for the innovation manager to tell me what new stuff we're going to do. So what we've always done, as you've seen, and it whizzed through quite quickly there, but at Epic, at Rock and at Icon, innovation is one of our core values. We have 4 core values across each of our business streams, and one of them is always about innovation. And it's not a fancy schmancy technical definition. It's just, to us, innovation is just finding new and better ways of doing what we do. What are you doing? Is there a better way that we could be doing this? Put your hand up and tell somebody. Innovation is part of everybody's job. And to me, that is a far, far more powerful way of driving thinking about change and what's possible with change and what needs to be changed than having somebody in an office being the innovation manager and determining that for the organisation. So that's something that's been really, really powerful for us. We celebrate, those values are absolutely key to everything that we do. We reward on those values, we fire on those values, we performance manage on those values, but most of all what we try and spend our time doing is celebrating our people who are actually living those values. And we actually, when we're saying to somebody, thanks, you've done a great job, it never stops there. It says, thanks for that. You've really delivered on our innovation value, or you've really delivered on our purpose value of delivering that exceptional healthcare. When we're thanking and we're rewarding and we're celebrating people, we always link it back to one of those 4 values. And innovation is always we have annual staff awards where people are nominated by their peers for how they've best lived to those values. And it's great to know that innovation has always been a really hotly contested category, because there are so many people that we can put forward for delivering on that value of finding new and better ways of doing what you do. The next part of it is, okay, so you've decided that you're going to go there, but you don't actually have an internal, because your IT team is generally not your digital disruption team. Your IT team is generally there keeping the systems running. We've all got a lot of technology and we're all very dependent on that technology. And if that technology doesn't work, the businesses are thrown into chaos and things just don't work. So having that team responsible for actually developing those and implementing those new and innovative solutions can actually be quite a challenge for them. You may take the path that we have, which is this is some of our internal team. They all wear jeans. We try and encourage them not to have their underpants showing over the back of their jeans, but they dress a lot more casually than the rest of the team. They have Play-Doh on their desks because that helps them with their thinking stimulation, and they don't tend to look much like the rest of our workforce. You may not want a team like that. You may not have the ability to create a team like that from budget or whatever constraints. But there are numerous small, medium and large firms that you can actually work with to be able to deliver those services on your behalf. Don't also fall into the mistake of thinking they have to have a healthcare background. The very, very best thing we ever did when we were going down this path, the leader of this team, who I think is the one taking the picture, which is why she's not in it, had no healthcare background whatsoever. She was a digital expert. She knew nothing about healthcare. And for the first 3 months, she just went around our sites and chatted to people, asking that question of where does it hurt? What are your pain points? And then she would come back and tell us what she'd found. And she constantly challenged that belief of, oh, we can't do it like that because we're healthcare, and healthcare can't actually function like that. And she would push back on me every time and time again and say, but why? Why can't you do it like that? Just because you haven't done it in the past doesn't actually mean. She goes, so all of these other industries, so your data is more secure than the banks. If the banks have been able to do this, why can't you? The fact that she actually had no healthcare background was a really, really invaluable thing. So don't fall into the trap of thinking you can only work with people who know healthcare intimately. Comes a point, patient records and privacy and the cybersecurity aspects, we'll hear more about that this afternoon, absolutely important. But if you only put people into these roles who think like you and who've only ever worked in healthcare and only know the healthcare way of doing things, the chances are that the disruption that you actually deliver as a consequence is going to be incremental rather than truly transformational. The other thing that's really interesting and a way of a light touch, I think, approach of doing that is actually, there's incubators and startup labs now in pretty much every city going around, whether it's a capital city or regional centre. They all tend to run hackathon days, and they're always looking for problems that people can take along to a hackathon day and get these teams of people who look like this generally to be able to apply their talents to and brainstorm and come up with solutions. Now, you may not go forward with what they've come up with. It's generally a 3 or 4, maybe a full day brainstorming session. They're certainly not going to solve the problems of healthcare within that. But if you identify a pain point and you take it along and say, here, have a crack at this for me, the way that they approach the problem and the thinking that they apply to it can be really, really interesting, and that in its own right can be enough to start to trigger some change thinking at your end around what's possible and the approach that you might like to take. So that's something that's maybe worth considering exploring as well. One of the things that why I think it's so important that we really focus on our small data issue now and in really trying to make steps along that pathway to resolve that is because the small data problem that we've got at the moment dwarfs into insignificance in comparison with what's coming our way. Our patients are going to be generating enormous volumes of data going forward. There is an avalanche of data coming our way. We're already all hearing the stories about the patients who are turning up with binders with their whole year's heart rate information printed out and bound to hand over to their doctor. No doctor wants to look at a year's worth of heart rate information. It's not important, it's not relevant. What's important, though, is the opportunity to get real, actionable, worthwhile insights from that data that our patients are being able to generate, blend that with the information that's in our systems, and look at how we can actually use that, again, to carry us forward towards our goal of our ultimate destination. One of the things that we're looking at, and I guess I wanted to show how you can use the same pain point approach to patient-generated data as you can with some of the examples that we've been talking about previously. So in this, I guess, journey of discovery around what our pain points were, one of the feedbacks was that in our chemotherapy centres, one of the real challenges is a patient will turn up for their scheduled chemotherapy, the nurse will take their vitals and go, heart rate's up, blood pressure's up, temperature's up, they're in the early signs of infection, I think, we're not going to proceed with their treatment today. Incredibly frustrating for the patient. You know, often they've organised they might have had a family member take time off work, or they've had to organise time off work themselves. They've come in to have their treatment. They've often travelled reasonable distances to get there, and then they're told, sorry, you've got to go home and come back again in a fortnight or when you're well. From a business perspective, that chair can't be rebooked. You know, it's not like a hairdresser when someone doesn't turn up for their appointment that you can put some blast out on your social media, quick, we've got a free slot this afternoon, going cheap if anyone's interested. You can't recruit chemotherapy patients off the street. You've actually not been able to utilise that resource for that scheduled time. The chemotherapy's been prepared. Chances are, you know, you're pretty lucky if it's a half-life and a dose and a treatment that's actually got an ability to be able to be repurposed for somebody else's treatment. So there's a lot of it's a pain point. So on a number of fronts. So when we're thinking about the data that's actually now becoming available to us through this world of connected patients, how could we use that to resolve that pain point? So what we're working on is a project there where we're looking at if we can gather information from patients around their heart rate, around their skin temperature, around their activity level, not diagnose from it, but look at the trend lines and go, okay, heart rate's going up, skin temperature's going up, activity level's declining. We're going to call this person and say, hey, we're a bit worried about what we're seeing here. We think that you might be starting to come down with something. Let's get you checked out. Or potentially, you've got an appointment for your chemotherapy starting in a couple of days' time. Let's actually start checking now whether you're actually going to be fit to have that treatment delivered at that time, because if you're not, let's reschedule you now to actually get you into the system for next week or next fortnight. Using that data, again, if you open yourself up to all of the data that's potentially coming there, you're going to get swamped by the avalanche. But if you use that same pain point approach, you're actually able, again, to target strategically what are the dots that I'm trying to put on that page, what is the picture that I'm going to get a clearer view of as a consequence, target that data and bring that in and capture it in that way. So the world of patient-generated data, I think, has an ability to be able to help us resolve pain points in a way that we've never been able to do so before, so long as we're smart and we're strategic and we're targeted in the way that we use that data. So I'm hoping that that's helped to give an illustration. You know, it hasn't been very matrix style. I haven't pulled things out of thin air. But what I'm hoping is it stimulated some thought around how you can start to take steps and increase the steps that you're already taking along that journey to digitisation, moving the needle from our current small data world to get us closer and closer to the big data reality that we all want to end up in. Thank you.